Mixed connective tissue disorder or overlap syndrome we are going to discuss now. These conditions are characterized by features of multiple autoimmune diseases like SLE, Scleroderma, Polymyositis, and rheumatoid arthritis. How to approach in these patients? So, in the history, we have to appreciate these type of patients. They present with a combination of clinical features from different autoimmune diseases like rheumatoid arthritis, SLE, systemic sclerosis, polymyositis, dermatomyositis. The common presenting symptoms will be like the general symptoms patient can have like fever, weight loss, loss of appetite, fatigue or tiredness. Then these patients can have Raynaud's phenomena, and this could be the earliest symptoms in mixed connective tissue disorder patient. They can present with cold exposure induced changes in the fingers and the toes. The color is changing and they are feeling uneasiness or discomfort and then the pain. Then the patient can have the symmetrical joint pain and also swelling. And the pattern of the joint pain will be like inflammatory type, more in the morning time, more after the rest, and associated with the stiffness. These patients will have the skin changes like sclerodactyly, that is tight skin on fingers, that is found in scleroderma. Other skin changes, these patients can have malar hair as in SLE, but these patients can have Gottron's patio or heliotrope rash that is seen in dermatomyositis. So these are features were present in our case that we discussed just now. Then the patient will have the features of proximal myopathy that is seen in polymyositis. Then our patient was also complaining that he was having problem while combing the hairs or shampooing the hairs. Then the other features in our patient was like loss of hair is present and oral ulcers were present that were not painful. Then the patient was having pulmonary involvement and the patient was having shortness of breath on exertion with dry cough, and there is no feature suggestive of heart failure in this patient. There is no history of toxicity nocturnal dyspnea or arrhythmia. But on examination, the patient was having a fixed inspiratory crepitation that was not changing with the cough. In our patient, there is no features of pulmonary hypertension, but in mixed connective tissue disorder patient, features of pulmonary hypertension can be present. If features of pulmonary hypertension is present, this is sign of severe disease and a serious complication is going on. Then we have to ask the esophageal dysmotility complaints, like any difficulty in swallowing or do you have any acid reflux. That will be predominant in scleroderma cases. Then the cardiac involvement is present in our case, and in such cases, with mixed connective tissue disorders, they can have features of pericarditis, myocarditis, or endocarditis, or they can have the features of conduction abnormalities. So, rheumatoid arthritis patient can have pericarditis, myocarditis, endocarditis. SLE patient can have pericarditis and conduction abnormalities. So, in our patient, he was having the features of pericarditis 1 month ago. Then the renal involvement is also present in our case. In mixed connective tissue disorder, the renal involvement, the kidney involvement will be less than in SLE. Patient can have the proteinuria, as our patient was telling, chlorinated of urine that we will confirm by doing the urine analysis. And if there is renal involvement, we should consider the kidney biopsy in our investigation also. So, overlap syndrome is defined by high titers of NP U1 RNP antibodies with the features of rheumatoid arthritis, SLE, scleroderma, and polymyositis, dermatomyositis. Sometimes there is another terminology is used that is known as lupus. Like lupus, this is lupus, rheumatoid arthritis plus SLE, sclerodermatomyositis, that is Oh, yeah, there is two terminologies. Sorry, the one terminology is lupus. Lupus means the combination of rheumatoid arthritis and SLE. This is lupus. Then another term is sclerodermatomyositis. There is the combination of scleroderma and polymyositis. These are two examples of overlap syndrome, where you can say that the patient is having the features of rheumatoid arthritis and SLE together. So this is equal to lupus. The other name is overlap syndrome. And another form of overlap syndrome is sclerodermatomyositis. Mainly the patient will be having features of scleroderma with polymyositis. How to do the workup in such cases? The diagnostic workup we have to consider according to the clinical involvement of the patient, the clinical presentation of the patient, then we will do the serological testing and then the imaging. So the detailed history followed by the focused examination to find out the features of Raynaud's, the skin manifestation, the joint manifestation, whether the dysphagia is there or no, the muscle weakness, polymyositis is there or no, whether the patient having respiratory manifestation, whether the patient is having cardiac involvement or the patient is having kidney involvement is there or no. These all we will try to find out. Then these findings will be confirmed by our examination. After the history, the examination, then we will go for investigations. So antibody testing to diagnose this problem. The most important antibody test here is anti-U1 RNP. It is highly specific for mixed connective tissue disorder. If your patient is having anti-U1 RNP positive, you can say it is mixed connective tissue disorder, unlikely to be overlap syndrome. In overlap syndrome, anti-U1 RNP may not be very high, but you will have the RA, rheumatoid arthritis, antibody testing positive, and SLE antibody testing positive. So it is lupus. Okay, and if it is sclerodermatomyositis, then the anti-SCL, anti-centromere antibody, and anti-Jo1 and anti-MI2 antibody will be positive in that condition. So one of the differentiating features between overlap syndrome and mixed connective tissue disorder is in mixed connective tissue disorder, we will have anti-U1 RNP antibody significantly or highly positive. Then the other investigations to find out the inflammation, how much it is. We will do the inflammatory markers, elevated ESR and CRP. Muscle enzymes will be high, like CK and aldolase. That will indicate the myositis. Kidney function assessment, we have to do the urine analysis, kidney function, urea, creatinine, and electrolytes to assess for nephritis. Then the imaging, chest X-ray for the lung involvement, high resolution CT scan for the lung involvement to find out the interstitial lung disease. ECG and echocardiogram to assess for cardiac involvement and to assess for pulmonary hypertension. Barium swallow to assess for esophageal dysmotility. Other tests we can think about spirometry and pulmonary function tests that will show the restrictive lung disease. Okay, some examiners may ask you about the muscle biopsy, so I told you when to do the muscle biopsy. Management in such cases, we have to adjust the treatment with the predominant features, what the predominant features the patient is having, and how much the severity of the disease is. So generally, We will do the education of the patient about the disease. We will counsel about the disease and the treatment plan we will give to the patient. We will inform the triggers, like the cold exposure is a trigger for Raynaud's phenomena. The smoking must be stopped. We have to inform the patient that it will be the contributing factor or aggravating factor for your problem. So highly recommended to stop smoking, and I will refer you to the smoke cessation clinic with other lifestyle modifications according to the scenario. So one by one, I will now highlight the management. Raynaud's management is avoid cold exposure, calcium channel blocker, for example, nifedipine. Topical nitrates or phosphodiesterase inhibitors can also be used for Raynaud's phenomena for severe cases. Generally, for pharmacological treatment for mixed connective tissue disorder, we can divide according to the disease severity. If it is mild disease and patient is having arthritis or arthralgia, we can give NSAIDs. For skin and joint symptoms for mild mixed connective tissue disorder, hydroxychloroquine will remain effective. But if it is moderate to severe disease, we should start with the steroid for active inflammation, like the patient with myositis, nephritis, arthritis, moderate to severe form, we should start with the steroid. And then we should go for to the immunosuppressants like methotrexate for arthritis and myositis. Other options, azathioprine or mycophenolate mofetil, if the organ involvement is there. Cyclophosphamide is given for severe organ involvement cases like in lupus nephritis and the patient with interstitial lung disease. Now, specific treatment for pulmonary hypertension, we should think about phosphodiesterase inhibitors, endothelin receptor antagonists, for example, bosentan, and the prostacyclin analogs. For esophageal dysmotility, we should consider prokinetic drugs like domperidone or metoclopramide, and if there is acid reflux, then the proton pump inhibitors will be the choice. So this is the brief summary about mixed connective tissue disorders.
For more detailed explanations and related topics, we invite you to watch our videos on our YouTube channel. Don't forget to like, comment, and subscribe to stay updated with our latest educational content. Thank you.